Intraoperative radiotherapy and its role in breast surgery is one of the lectures that I gave in this conference. Now, breast conserving surgery involves doing a lumpectomy, which is a wide local resection, some form of axillary dissection, but this has to be followed by radiation therapy to the whole breast, which can take about 3 to 6 weeks. A lot of women never receive radiotherapy because of the burden of traveling to a cancer center for radiotherapy, and some women are scared of radiotherapy. So some women choose a mastectomy because they do not want radiotherapy. Even after breast conserving surgery, it's been estimated that about 20% of women never receive the radiotherapy that they were supposed to for various reasons. So accelerated partial breast irradiation means irradiating a portion of the breast where the tumor was for only a shorter duration of time. And there are 3 methods of delivering accelerated partial breast irradiation, or APBI. These 3 methods are brachytherapy, external beam irradiation, and intraoperative radiotherapy. I'm talking about intraoperative radiotherapy, where after removal of the breast lump, a spherical applicator is placed into the breast cavity. Radiation is applied through this spherical applicator. About 20 grays is applied over 30 minutes, and then this applicator is removed and the wound is closed. So this is very comfortable for the women, and they do not need this long duration of radiotherapy. So it is good for women who live far away from the cancer center, so they do not need to come every day for radiation therapy. However, this method is only suitable for a select group of women, and there's at least 3 societies which have given recommendations or guidelines to the use of APBI. So only a good prognosis set of women, that means women more than 45 years old, women with a tumor that is less than 3 cm, lymph node negative, and good pathological features such as estrogen receptor positive, progesterone receptor positive, HER2 negative, grade 1 to 2. These type of women are suitable for monotherapy, which means a single shot of intraoperative radiotherapy. If they do not meet this criteria, then after this single shot of radiotherapy, they're given 15 times external beam radiotherapy, which is EBRT. This still shortens the duration that they have to come for radiation therapy. A randomized control trial called the Target A was published in the Lancet in 2013, where over 3,000 women were randomized to either external beam radiotherapy, which is the traditional 6-week course of radiotherapy, versus the intraoperative radiotherapy. And this trial has showed equivalent outcomes in terms of local recurrence and survival. In fact, a recent meta-analysis shows that the mortality was actually lower in the intraoperative radiotherapy group, partly because there is less non-cancer deaths related to the radiotherapy, such as cardiovascular mortality. But even with all this data, there is very little consensus among the physicians about how safe it is. And also, we must remember that especially in Malaysia, there are not that many women who meet this good, favorable histology group of patients, because if a woman is node positive, then IORT would not be suitable. But we do have quite a large group of women with the selective good prognostic factors that are suitable for IORT. So in conclusion, I find that IORT is actually safe, and it gives equivalent results, and it is more comfortable for the women. And in places where the women live far away from a cancer center, it would be ideal.